This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, July 15, 2024. I'm Len Sierra. I'll be moderating today with a little help from my friends, our fellow moderators, and all of the attendees here. And as we always do, we want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth. Okay, we are going to start with Nick Young, who is new. So, Nick, I'm going to go through a few questions, and just to help try and keep you in chronological order in your story,
Okay.
try not to jump ahead. All right, so Nick, how old are you?
I am 64.
64. And where do you live?
Tampa, Florida.
Tampa, okay. And how did you hear about AnCan?
I got something in email.
Okay. And Nick, when were you first diagnosed?
In November of 2015.
Okay.
Julie and Mom, in general, you're off camera. Secondly, you are
Mark, I'm going to mute. Okay, good. Somebody muted. All right. So 2015, that's 9 years ago. You were only 55 at the time.
Mm-hmm.
And what was your Gleason score and PSA at the time of diagnosis?
At time of diagnosis, my PSA was 76, and then within like a week, it was 96. And my Gleason score was 10 plus 10, or 5 plus 5 equals 10 across really all the core biopsies. So it was all very aggressive.
Yeah. Well, so first, let me congratulate you for still being with us and seemingly in good shape after 9 years of Gleason 10. So who did you have for your primary therapy? Did you have radiation or surgery?
Did not have surgery. So it was metastatic from the beginning. So it was stage 4, and it was in my bones, in my lymph nodes, in my I probably had like 5 or 6 spots in my spine, in my iliac crest, and it was around. So it was suggested that we move fast, and I really it was in Northern California where I got diagnosed. So I was living there at the time.
All right. So what was your first treatment regimen?
Okay, so right away, I went to that support group, and the guys made some suggestions. Fortunately, it was like the last group meeting before the holidays, and I would have been able to get into a meeting for a while. And I had some not so motivated urologists, like, yeah, hey, our oncologist will be back after the holidays, so no problem. You can get to him then. Like, my wife and I were just livid. So anyway, we lined up like 6 oncologist appointments, and we built a treatment plan from prostate cancer, or I don't remember the exact name, but they're the guys in Marina Del Rey, Schultz, and Turner, and those guys. So they designed the plan, and then my doctor Shane Dormady implemented the plan, and it consisted of both of their plans were very similar, but what I went with was what Turner's group did, which was doxytaxel right away. So I had chemo 6 rounds, of course Lupron, had Xgeva right away, and Xtandi. So I started on that triple treatment immediately, and it did well for me. It brought my PSA down to undetectable within about 9 months. And then I really credit Xtandi with keeping me there throughout the duration. So I was in remission for 7.5 years. Just recently had relapse. So we can
Wow.
talk about that. So
Wow.
So you were undetectable for 7+ years?
yes, after about a year, we went in and did brachytherapy to the prostate, of course, and then we did IGRT for the prostate bed. So to try to, hammer it down and secure it a little more. So all of those things worked amazingly well, and I feel very fortunate. But I just had a chemical reoccurrence. So if you want me to talk more about the first time or what's happening right now, I'm happy
Well,
to
I'm
do either.
just curious, not that it matters for treatment purposes, but um, what alerted you to go and have your prostate checked? Were you experiencing any pain,
No, I was experiencing had to urgently urinate.
or was your
Urgently.
only symptom?
Yeah, it was my only symptom. And the funny thing was, I went in January, and for some unknown reason, my doctor did not make sure that I had a PSA. He might have told me, I don't remember. I probably wasn't the best at following directions anyway. But I never had a PSA in January. So he's like, well, man, just give you some Flomax. And it treated the symptoms. And so I went on my merry way until really it was about October when I had those symptoms. And I went in late October and I went in.
Yeah. So, well, your doctors were kind of ahead of the curve in your triple uh, therapy, which has really only been established for people in your disease stage, you know, uh, within the last couple of years, I believe.
Yeah, I
So
mean, he was really aggressive and we wanted something aggressive. So we kind
was
of
it
sought
was it Turner or Schultz or just
it was Turner who designed the plan and Dormady who implemented it.
okay?
The only difference Dormady would have done was he was going to suggest cabazitaxel instead of doxytaxel, and he would have done Xgeva instead of Xtandi. So,
So Nick, have you had any genetic testing done, whether germline or somatic?
well, I had the germline testing through Foundation back in the beginning,
Yep.
and so it's like I have. I think the main things it showed were like P10 and what is it called? 53 something.
TP53.
Yeah, TP53.
Oh,
Okay.
interesting.
Uh, so that was somatic testing from the tumor, right?
Yes, that was from the tumor.
Yeah. Okay. And the germline inherited testing, that was all negative.
I don't know. I don't know what you mean by that.
The genes you were born with for mom and dad.
Oh, yeah. I don't know.
Okay.
I don't know. I just knew it
Have,
was.
have, have you ever had them tested? Those germline? Have you ever had a germline test?
Well, we might now because tomorrow I'm going for a biopsy. So, so my PSA was undetectable the entire time, as I mentioned, and then just within, well, I had my regular PSA check, and it was basically, all along had been point 0.1 or point oh 0.01 or lower, and now it's point 0.5. So from January to now, it's clipped up to that. So and part of the reason I had it scheduled at this time was I've been doing my remote oncology visits with my California oncologist, and I do also have a local oncologist, which is very practical, of course, to have tests and scans and all that of my regular basis. But so they ordered a PSMA PET, and it lit up quite a bit.
Hmm.
So a lot of my lymph nodes in various areas are involved. So,
So let's just come back a second
okay.
to this germline, okay? So your mutations that they found were mutations that you may have made in your own body because we looked at the tissue at the time in the from the tumor. However, you can also inherit, and what Len was asking you was, do you know if you've inherited anything now? P10 and TP53 can both be inherited, but it's very rare. However, if you have offspring, if you have brothers, sisters, what have you, you should get a germline test. It's a very simple test. We'll put a link for it in the chat window. There's a test there's a trial that's going on right now, and they'll send you a swab, but you should rule out that you don't. The TP53 is called Li-Fraumeni syndrome. P10 is even rarer. We don't see it very much, but it should be ruled out. And you don't even need to bother the docs with it right now. At the same time, and I don't want to get ahead of us, but you probably need to be resequenced 7.5 years later. But Len, let me go back to you. Sorry.
Okay. All right. So your PSA is currently 0.5. By the way, have you been on that same triple drug regimen all these years? You never
Yeah,
took a drug holiday, right? Okay.
the entire time.
Right.
Oh man.
Okay.
Well, I was also taking tamoxifen too. I don't think it had much impact, but I wanted to try to minimize
Yeah.
my boob enlargement.
All right. So have your docs come up with a plan going
Yes,
forward? What do they want to do?
yes. So I did some research on this as well, but it made sense to me. Pluvicto and Zytiga right now. He's not so sure that Zytiga will have a huge effect, but he's pretty confident that based on how I present right now, Pluvicto should be really a good move.
Yeah, but you've got to go back to him, and we'll give you the reference, and you got to tell him that you got to get sequenced first, because with
What do you mean by
PT
sequenced?
somatic sequencing, because with P10 and TP53, you're not a good candidate. And is this Schultz you're that's recommending this?
No, it was Dormady.
Okay,
Uh,
well I mean, Dormity's good. I assume you were part of the San Mateo that was the virtual support group that you were participating in, right?
yeah, it was like Mountain View actually.
Yeah, the Mountain View one. Sorry, I get it wrong, but it was in. You got to. We'll give you a reference, but you got to show this reference to him that there's recent research that tells us that with P10, TP53, and RB1, amongst others, but especially those, you don't do well on Pluvicto. And
Okay.
we've seen it with guys. There are guys. There's even somebody in the group right tonight. And what we don't want to do is waste weeks or months. So you may be a better candidate for a different type for a different type of chemo. I mean, Dormidy's a radiation oncologist, right?
No.
Or is he? No, he's a medical oncologist. Right. Um, but yeah, we'll put it in there. But there's a lot of new stuff coming out, and it's emerged in the last 6 months about sensitivity to Pluvicto if you carry certain mutations.
Okay. I
Hmm.
will definitely check on that and have that discussion with him. Now, let me ask you guys. So I'm going to have a biopsy tomorrow. So they're going to go into the lymph nodes. It's the only places it's gone to at this point. And Shane Dormady said something about, we could send that off for probably what you're talking about. But when I did it, it was just like, oh, let's send it off to Foundation, and that was that. and I never resequenced anything. So how do I go about that? Just ask the doctor and he'll be able to point me in the right direction. How we do
But
that?
yeah, tell the doctor you want to get it resequenced. We'd suggest probably Tempus today, but don't let him send it to Guardant, and because I know that's some of the doctors like Guardant. We would not recommend Guardant. We'd probably recommend Tempus, possibly Foundation Medicine. Boston Gene is real good right now. Caris, but I think Tempus would be our first choice.
Tempest, or like Tempest, Tempest.
Tempus. He'll know. Dormady knows. He's
Okay.
good.
Nick,
And
excuse me a
does
second.
insurance cover that these days or not?
Yes.
Yes, it's well. Are you on Medicare or not? How old are you?
No.
60.
I mean,
No.
I have insurance, but
Right. No, it should be fully covered. Go ahead, John.
I thought I heard, Nick, I thought I heard you say that it's just it's just in the nodes now. Did all your bone metastases disappear over the years?
yeah, all the bone metastases totally disappeared the first time. And so when it's
Cool.
come back, it's just all been in the lymph nodes in multiple locations. There's quite a bit of involvement, but it's only lymph nodes.
And the prostate, of course.
Well, I mean, yeah, but we pretty much hammered that with the brachy therapy and all that. So, but I think it's still lit up.
Okay. Thank you.
Sure.
All right, so you're just going to be waiting on the biopsy results from one of the sequencing companies.
Yeah, and they also ordered a BRCA1 and 2.
Yeah. Well,
Wait, wait a
they'll
minute.
pick that up.
Yeah,
They'll
but
pick that
why
up
would
in
they?
the biopsy.
Yeah, I mean, I don't know who ordered the BRCA1 and 2. Dormady?
My oncologist here. We were kind of scratching our head on that one.
Well, yeah, I mean, what he should be ordering is a complete sequencing.
Yeah.
I mean, these
Yep.
guys, yeah, okay.
Maybe that's what he meant, Rick. Like we're going to order BRCA1 and 2, but he really meant
Could be,
OB.
yeah.
I don't know.
No, I mean it was via a blood test, so I don't. Is that how they
Oh, a
do that?
blood test. Oh, so they were looking to see if you had germline BRCA.
Okay.
Well, they may have been doing a liquid biopsy and not
Well,
telling
Yeah.
him,
yeah, that's true
so
too.
he could have been doing a liquid biopsy, but yeah, but
Yeah.
just hopefully they'll get enough tissue out of the lymph node tomorrow, and they'll send it off to Tempus, and then what you do need to do though is get a germline test just to verify that none of these mutations that you might have are inheritable. And
Okay.
somebody will put, or I'll put the promise in. Right now I'm just looking for the oh, here it is. I've got it right here. I'm going to put the link. So do you know where the chat window is, Nick?
Yeah, I sure do.
Okay, so I'm going to put the link in the chat window right now.
Okay.
This is from ASCO. I think just this year. Hold on a minute. Let me make sure I send this to everybody. If you click on it, well, I meant to send it to everybody and I sent it to the organizers. Let me try again. All right. If you click on that, it'll open up in your browser.
Uh-huh.
Genomic correlates of PSMA antigen expression and response to PSMA 617. And that's what you got to give to Dormady. And you got to have a real heart-to-heart with him as to whether he thinks, is he still your quarterback, or you haven't shifted to anybody in Tampa?
No, I haven't relied on anyone here in Tampa.
Well, you know, the person we really like isn't actually at Moffitt, and she's really good. She's in Sarasota, right, Len?
Yes, you're talking about Guancial?
Yeah.
Yeah.
What is her name?
So
Yeah, she's with the Florida Cancer Specialist in Sarasota. Her name is Elizabeth, Guancial.
Oh yeah, I've heard about her. Sure.
Yeah, she's excellent.
I mean, she trained with Dr. O. She's really good, and frankly, she's probably um, on that east on that west coast, that northwest of Florida. She's probably as good as anybody at Moffat, and she's lovely, right, Len? She's really
Absolutely.
she's
Yeah, wonderful.
compassionate. She's really nice. We'll put her link in there, and you can
Okay.
tell her Len sent you.
Okay, Lynn, thank you.
Because Len sees her and he sees in the winter and Dr. O in the summer. So
Yeah, and I find them to be equally good, to be honest with you. I don't see that Dr. O has much on Dr. Guancial. I mean, they're both equal in my view.
and the other thing is that there are other papers. I just put one of these TP53, one of these gene papers in, but there's about three of them. I just can't find the others right now, but there's about two or three of these gene papers. Garden themselves did one. I can put that in. Similar results. But you know what we're telling people now is that if you've got unusual disease or any, you know, you think you've shown these somatic mutations, you've got to get sequenced before you start, because we've seen at least two guys that I can think of, if not three, who had the triple whammy. They had P10RB1 and TP53, and they just have not done well on. And then there's a couple of others we're learning, which are these what they call tumor suppressor genes. So there's some debate about this, but genes like MSH2, MSH3, and SPOP may also be tumor suppressor genes. And when you finish up with two or three of these, it can really get in the way of the Pluvicto,
Okay.
as Mark Finn, who's in the group, will tell you.
Nick,
Okay,
I assume you know about proper nutrition and exercise for prostate cancer.
I know about it. I don't always practice it. My wife will tell you that.
Okay, well, never too late to start. Very
Yeah,
important.
at this point where she's already getting me going. Um,
Yeah, it's been proven to be effective
If they have a book.
in dealing with prostate cancer.
what kind of book, Michelle?
A cookbook or
Oh, is there
something they have.
a nutritional cookbook or something that you would recommend?
Well, the Prostate Cancer Foundation has a free handbook for like something like Guide to Prostate Cancer, and they have a substantial section on nutrition, or they may even have a separate publication on nutrition. So unless
No
anybody
more
else,
red meat. No
sorry.
more red meat.
Yeah. So there are a number of books on nutrition and diet. Len's recommendation for PCF is a good starting point. And your wife is very welcome to come into this meeting, by the way. We love having care partners. She can sit next to you and we can talk to her as
Okay.
well. She's
Okay.
very welcome. We also have a care partners group. They're meeting this week. They're meeting tomorrow, same time, same place. And she's very, very welcome to join. Now, I don't know we have time this time, but come in next week, talk to us, and we'll start putting on the lead to some of these nutrition. One thing you can do is just type nutrition or cooking into our website. We've done a bunch of webinars on it. Listen to them. Um, we have worked very closely with UCSF ever since 2008, 2007, 2008. They have some great dietitians up there. We've done webinars with them. We've done webinars with other people, so that there's lots and lots and lots of good stuff in there. And maybe some of the guys will put leads for you in the chat window on books that they've used or what have you. I put Elizabeth Guancial's
I saw that.
link in there. So she's what, an hour from you in Sarasota?
Yes.
So yeah, I mean, I would say it's probably going to be easier to park than going to Moffat anyway. So uh, that's I think that would be my personal top choice there. I'll continue to put a couple of other links for you on the Pluvicto mutations issue that you can send to Dr. Dormady, and you've really got to be mindful about making that decision, dependent on what comes back from Tempus.
Sounds good. Thank
The
you.
other thing that our experience has been over the many years that I've been doing this and others, you need to keep the cancer off balance. And to be on enzalutamide for, how long have you been on that enzalutamide? 10 years now?
Yeah, 9.
9.
Well, yeah.
Yes, 9 years? Or have
Well,
you
since
been?
2015, so
Yeah.
16,
So
17, 18.
9 years. Have you, it's good to stop it for a while, restart it for a while. I mean, not to stay on it, because what we found is that when people stay on the drug that long, it's very difficult to find another treatment for them because the cancer's gotten too smart. So it's good to chop and change. And,
Well,
it's,
it was working so well, right?
yeah,
I mean,
got it. No, I get it. I get it.
So Nick, do you have any other questions for the group before I open it up to them?
what we're talking about Pluvicto, that's what we're talking about.
No, the other drug, the,
Zytiga?
yeah.
Oh, in terms of Zytiga, have any of you guys been on it? And what about the fact that you're also on, what's the word?
Prednisone.
Prednisone. Prednisone. Because my wife's all concerned that prednisone is going to be bad news. But
Yeah, lots of guys on Zytiga and prednisone. Anybody want to jump in?
The one issue is that they usually find that you're better off doing Zytiga before enzalutamide. But it as Zytiga does have some issues, the prednisone's no problem at all. It's not very much, but Zytiga does have effects on your heart, and will probably raise your blood pressure. I don't know if you have blood pressure's high already, but it probably will be if you're on Zytiga for a while. Hot flashes with Zytiga can be more severe, especially since you're on enzalutamide. But just make sure you exercise regularly. Diet is so critical. If you were to go total vegetarian right now, you might live another 10 years. It's that important to manage your diet. It really makes a major difference for people that, especially with high Gleason scores.
all right, thanks, Joe.
John, did you want to jump in there?
Oh, Len, you just caught me as I was exploring something else.
Oh, okay. That's right.
I wanted to say that in terms of you and your wife looking up dietary information that's easily digestible, so to speak, by the layman, that I like that Anticancer Lifestyle Program that I just put into the chat.
I
They
think
have several little patient brochures that are for free about eating by dietitians.
awesome.
I got two hands raised, Jim Marshall and then Gary. Go ahead, Jim.
Uh, Nick, are they talking about putting you onto the 4 pills or the single pill? Or have they actually discussed that yet?
We're not there yet. You're talking about the Pluvicto?
No, I'm talking about Zytiga or abiraterone.
I don't know. We're not there yet. We just he was going to prescribe it, and so I haven't started this treatment yet.
Okay. Oh,
All right. Gary
another
and then
question.
Dr. Jeff.
Another
Suggestion?
question. Nick, are you a veteran?
No.
Okay, I thank you very much.
Gary?
If and when you come off the abiraterone and prednisone, just make sure you come off the prednisone in a very slow tapering.
Yes.
If your doc tells you you can just stop it or stop it over the course of a week, some people can get away with that. A lot of people can't. And if you come off too fast, you can get in a lot of trouble with your adrenal glands.
Okay.
Okay, we're getting a little ahead of ourselves. He hasn't even started it yet, Gary. So
Right, sorry.
No, but it's
Yeah,
that's all right.
yeah,
Dr. Jeff and then Dr. Mark.
Yeah, so I take abiraterone and prednisone. I only have 399 more days to be on them. Okay, I count, but you should be able to get an easy remote meeting with a nutritionist through your hospital. I had one. I'm with Get My Care at Memorial Sloan Kettering, and they arranged it. It was very simple. It was a virtual meeting, and you learn everything you need to know about what you should eat. Probably the Mediterranean diet style is probably the one of the better ones. And I did put an MSK PDF for you in the chat, which is a very extensive prostate cancer diet and uh, literature, uh, and of course exercise. What I caution is, and I don't think I'm unusual, fatigue is at times overwhelming on the abiraterone.
Oh.
That's why you take prednisone.
Well, he's been on Zytiga, enzalutamide for 9 years, Jeff. So I have a feeling he can handle Zytiga. But
Yeah, I also work full time too, so this is, I don't know, some days how I
Ask
do.
if anybody has a connection with that female doctor.
no,
Oh,
no brain fog. No brain fog with the Xtandi.
oh, yeah. I mean, yes. So I just have to work around it. I have to drink coffee and leave myself breadcrumbs with in Outlook and in messages, and gotta take care of myself somehow.
Good.
I've also added the UCSF nutrition for prostate cancer, which is written by Greta McCare and others, which is very, very good. So
Oh, okay,
between
cool.
the MSKCC one and the UCSF nutrition for prostate cancer, and the UCSF one has recipes in the back. So so that's good for the wife.
Ask them
So
if they've heard of Cancer Free with Food.
Cancer Free with Food?
That's a book, yeah.
It's a book. Have you heard of that, guys? Cancer Free with Food?
yes, and also what's her name? Oh man, I'm just blanking on it. She was just on a. I just saw her on a webinar. I think that's the one you're talking about. Who do you have the author on that?
Yeah, hold on just a sec.
She'll get it.
Yeah, I'm pretty sure that's the one that I'm thinking of. I have a copy of it here, and we've had that lady too. She's from Marin. She's a Marin person. That's not a
Lena
good thing.
Werner Gray? Is that what you said?
Who?
Lena Werner Gray.
Liana, maybe
Lana Werner
Liana.
Gray.
No, that's not who I'm thinking of. I'll put another one. I'll just go get it, and I'll put another one in the chat window for you. Go ahead, Dr. Mark. You go
Yeah,
ahead.
Dr. Mark, go ahead.
Okay, I posted an article, a review from Alan Adele on some of the literature and studies on diet and nutrition. And the studies are, I mean, it's important to do, but the data is weak. And certainly, I've seen too many people who assume that they're going to cure this and ignore what their docs who are experienced in managing prostate cancer do. So diet should be something adjunctive to traditional medicine and not be looked at as a sole source of treatment. With abiraterone, I want you to know that initially when it came out, it was 4 tablets a day. It has since become generic, so it's a little bit cheaper. But it turns out it works just as well if instead of taking it fasting, you take 1 tablet a day and you're not fasting when you take it in the morning. So if they want to give you 4 tablets a day and you find it's going to cost you a lot, go ahead and just Google low dose abiraterone. And the main thing you're looking to do is to bring down the testosterone level. And my experience with that was prior to generic, and it was going to be about $3,000 a month. And I got down to 1 prescription, 30 tablets a month, and it was a lot easier to manage.
All right. Jimmy Greenfield, you're up, and then David H.
Hey, I just want to say it's been an awful lot of talk about nutrition here. We kind of glossed over the exercise and how I feel about that. Dr. Mark says that the data is weak on nutrition. The data is strong on exercise. It's very strong. And I would hate to see us gloss over it. That's all I'm saying. It is every bit as important and probably more important than diet.
Guys, just one quick question. So, does anyone have a relationship with Dr. Guancial in
I do.
Sarasota? Who does?
I do, Len.
Len? Yeah, if
Yeah.
could you possibly help me with an intro there? Because it may be just trying to get the appointment kind of quick.
Sure. Um, let's see. I don't know. What info would I need about you? Just your name and email address, or how do you want to do this?
Just get his phone number and talk to him off this.
Yeah. How about it, Len? We just work that offline. I'll just call you.
Yeah, good idea.
Get his phone
Okay.
number.
You can just give it to me and I'll write it down. Or
Nick, do we have your email address? Have you signed up for a reminder yet for these groups or not?
I may have because I was receiving an email, but it's I can give you I'll put my email in the chat if you want.
Yeah, if you would, put your email in the chat, and then Len and I will just follow up, and we'll make sure.
All right, that sounds good.
And we'll make sure that that your property signed up. And the book I was thinking of was Cancer Fighting Kitchen by Rebecca Katz, which is pretty good too.
David H., you had your hand raised. Oh, David, we can't hear you. We still can't hear you. Did you log off and log back on? Yeah, it didn't help.
Yeah. David, I suspect this could be in your settings. It's not picking up the microphone. We'll give you another solution. We'll put you can call in, and so you can leave your camera on and just call in. So we'll see you. I'll put that in the chat window for you, or somebody will put it in the chat window for you momentarily.
Okay, while that's happening, let us go to Dr. Jeff. You said you wanted some time tonight.
Yeah. So I came in late last week to the meeting, quite late, and there was two discussions that I just wanted to briefly comment on. One was the discussion about the significant amount of discomfort that men experience when they undergo radiation therapy and have to drink water to keep their bladder full. I went through that, as I'm sure did many of us. And I had 48 treatments, radiation sessions, but after the 32nd one, I had an appointment with my urologist, and I've mentioned this before, but the game changer drug for me that took away all the discomfort of having to drink that water and have a full bladder, and maybe there was a delay in front of me. The game changing drug was Gemtesa. And I brought this up before. That's generic Vibergon, Vibegron. It's a beta 3 adrenergic agonist. It relaxes bladder muscles, and it just changed the landscape. So if anybody's dealing with that, it's a good drug to talk to your provider to give you. You take it once a day, and it's very comfortable.
It's very expensive, isn't it, Dr. Jeff? I found it was very expensive.
I don't know. I got it with through my insurance for like $5. So that I don't know. Cost me $5, but it was a game-changing drug in terms of comfort. The second,
for me.
What's that?
It was $300 a month for me after insurance.
Wow.
That's why I didn't take it.
Mine
But
was $5.
my Vetric is good also. And it's a little bit less.
The second one was actually a conversation related to you, Jimmy, and the recurrent cellulitis. So one of the things for staphylococcal infections, and especially MRSA infections, so I would assume that strep would also be on the list of bleach baths as a way to keep the bacteria at bay. And I took care of a lot of patients who had MRSA infections, and bleach baths often help them. It's a half a cup of bleach in a bathtub of water. You sit in it 20 to 30 minutes, 2 to 3 times a week. We use it in people with eczema. We use it in people with MRSA. It might be something you want to chat with your doc about to keep this infection, this cellulitis you're getting at bay.
It's interesting. Do you think if I filled the entire tub with bleach and just do it once a month, it would be the same?
We've never seen you again.
Hey, Jimmy, it would turn your hair blonde.
Yeah,
And you won't have COVID.
Yeah. Thank you, Dr. Jeff. I'll look into that.
Jimmy, I just want to tell you, I asked my best buddy about his experience with radiation cellulitis over his career as a breast cancer surgeon. And he said, he did see it relatively frequently. and the prescription and the would prescribe low dose antibiotics, which is similar to what they're saying to you when it comes on. So, but I did check with him, and he was very much aware of it.
Thank you very much. Can't hear you, Len.
David H., are you back with sound?
Okay, you can. I put the
You
call
can't hear
in
me?
for you in the chat window. So if you dial in with that, we'll see you come on.
All right, we're going to go with Mark Finn, who is in home hospice, and he's going to tell us about that. Mark, are you with us?
Yes, I am, and not only am I
Good to
with
see
you,
you, Mark.
upper left-hand corner should be. At least I see you guys.
Oh, I
Can you hear
got
me?
you. I got you. Okay.
Yeah,
Yeah, perfectly well.
yeah, you guys got me confused now. I'm just, yeah, that's interesting. All the stuff you've been saying, because I've sort of moved beyond the nutrition stuff and so on. So I was trying to pull up a web. I'm trying to pull up a website where I basically a spreadsheet where I keep track of all this stuff, and you guys are talking about stuff that I'm not keeping track of, so I have to put that on my tickler list for tomorrow. I try to just, because I wasn't getting anywhere. Let me go back and tell my story and try to keep it as quick as possible. And Rick, if you could, and Len, if you could keep track of my time, because otherwise we'll be here till tomorrow morning for breakfast. Okay, so my
Mark,
situation.
could you get closer to the mic? My hearing isn't that good. I can barely hear you.
How about now?
Well, I meant your voice, but yeah, okay.
Well, it should do both because I got a
Yes,
laptop.
it's better. Thank
Okay,
you.
all right. Okay, so I was diagnosed in 2015 with metastatic disease, and I was diagnosed initially with a metastatic stage 4 prostate cancer. And so at that time, I went on. And guys, I got a little bit of brain fog, so you have to be patient. Sometimes it takes me a while for me to get the words out. So anyway, so I went through some initial evaluation, did an assessment on my own, and then I finally decided I was going to go ahead and get a prostatectomy. Because it was metastatic, there, obviously is questions about should I really have a prostatectomy, or because it's already out of there, just let it go. And I finally decided after a lot of extensive research, and people recommended different things, that it made sense for me to have made sense to me to go ahead and get a prostatectomy. So I went ahead with that. And so I had prostatectomy before the end of 2015. And then from that, from that, we decided that we'd do that. And actually, I've always credited, by the way, because I'm not off stuff, I get kind of weird and weepy. So if I start crying, don't worry about it, guys. It's not my grandchildren smashing my toe. Anyway, and so I went ahead and had a prostatectomy, but even though triple therapy was not really state of the art then, I went ahead and got a triple therapy and got some docetaxel. Took that for, I believe at that time, it was 6 treatments, 6 weeks apart, or about that. So I did that, and immediately went into remission, at least according to PSA. And I knew that there was a good chance it was going to come back. It's just a matter of not if, it's just when. So I knew those risks. And I also, read most of Walsh's book, Text, on a variety of things, and went ahead and got my different thing. I went ahead and did that. And then I met up with this group, and Rick's been very helpful in getting me integrated into it. Turns out that 7 or 8 o'clock on Monday or Tuesday aren't great nights for me, so I've been lazy in attending, and I'll have to try to get back into it because you guys are talking about a lot of stuff that I'm aware of, but I don't give much priority to. At the same time, I started exercising more, and for a long period of time, I was very active in doing the exercise bit. So I do that at least twice a week. But I gotta say, eventually, I sort of fell off the wagon. I cut off red meat, cut off alcohol a little bit. I'm not a big drinker, but I do enjoy my glass of wine. I'm with my wife on the back porch. So because I enjoy that, I gave that priority over going to a non. I made the choice that I was going to go ahead and continue to have my glass of wine, and I'm glad I did. It gave me a splendid 7 or 8 years. So then I went ahead and I was trying to get this again. This is what I was looking frantically for you when you guys are having this discussion of this. But anyway, I'll have to find it. I have this document where I sort of go through the chronological order of this stuff. That lasted for about I had some remission for about 6-8 weeks, and then after that 6-8 weeks, it tended to my cancer came back. I mean, my PSA, initially when I had my biopsy, I was I was like 4 or 6, and I was also I had 4 to 6 in my prostate, and then from there I went to let me see, and then from there I did Provenge. That's why if I can find that spreadsheet, I'll send it around to you, Rick, and you can share it with the group so it'll be a little clearer.
I've got it all here. You want me to run through it because it's a long list, and I
Okay.
can go through it for you pretty quickly. So
That would do me 2 things. If you could read it to me and to save me about an hour of looking and send it back to me because I don't know what I
yeah,
did.
no, I'll copy it and send it to you. So you were
Okay.
seeing Walter Stadler.
Yep.
You had TP. I had this very early on. You knew that you had TP53 in your
Yep.
mutations. You were
Yep.
seeing Walter Stadler.
Mm-hmm.
You stayed. Let's see. You were on ADT alone, Trelstar, for about 9 months. Then you took a 6-month holiday. Went back on in 2017. Mid 2018, your PSA was creeping up, and you did Provenge. Your PSA stabilized at around 4.0. You started thinking about Xtandi. You did some spot radiation on T6. Brought your PSA down to 2.5. That was in April of 20. You went on to the low dose protocol of Zytiga that we were talking about, with 5 milligrams of prednisone and the no fat breakfast. PSA was down to 2.0. You did Xgeva. Not much fatigue, which was all good. At the end of 2020, the ADT started to fail. The hormone therapy started to fail. And you were going to do another Axumin. I think you may have switched to enzalutamide around that time.
Yep.
I have, at the end of 21, you had spinal lesions, and you were thinking of doing chemo again, maybe Jevtana. And Len suggested you might want to, well, I'm not sure how this fits in, but Len suggested switching to dexamethasone. So I don't know if you were still on abiraterone or if you were on the enzalutamide. Let's see. Yeah, you were looking at an enzalutamide trial. You were thinking about a small molecule PSMA trial with 131. PSA was holding steady, plus or minus 6. You did a short period with chemo, but you didn't do very well on it. You had some jaw issues. And I think I have you were doing well on a trial, so I'm not sure which trial that was. Was that an enzalutamide trial? Was that radionuclide I-131 with enzalutamide?
It was iodine. It was iodine instead of lutetium.
Yeah, iodine 131. And so where are we? 422, your PSA started rising again. 6 to 8 months, you went on to cabazitaxel. You looked at another iodine trial, PSMA trial. It got you back down to 2. Crept back up. You did some more cabazitaxel. PSA got up to 22. There were bone mets. You were thinking about doing a CAR T trial that never came about. Then you started thinking about Pluvicto, and I have you starting Pluvicto in early October of 22. You did 2 sessions of Pluvicto. PSA was steady. Slight increase in your PSA from 28 to 35. Still thinking about the CAR T trial. We're now in March of 23. You completed your Pluvicto. Your PSA was holding steady at 30. But the Pluvicto didn't appear to show benefits. You were thinking about the AMG 509 T-cell engager with Danila, and we connected you to Dr. Evstathiou. And around that time, your PSA started to really jump, went up to 360. You tried olaparib and abiraterone. PSA stabilized at 350. You were accepted for the androgen receptor destroyer, ARV-766, but you couldn't get your hemoglobin up. You tried some Xofigo, and it brought you a lot of pain, and then you decided to enter hospice. So that's what I got, and I'll copy that and send it to you right now.
If you could, that's very much appreciated. You saved me a bunch of time. Anyway, and so that's kind of my story, which in a minute I'll stop and you guys can ask any questions. So the key thing is I was going to go into a clinical trial at Northwestern with Vanderweel, and it turned out that they were not going to take me with a PSA, with my PSA being less than 10. And so, and if you look a lot of the, PSA, hemoglobin less than 10. And if you look a lot of these clinical trials, that's kind of you have to get that. If you don't have less than 10, they're not going to let you in the study because they're concerned about anemia and edema. And so it's true that I've had edema. My legs swell out. I'm the Pillsbury Doughboy. And then I also get a lot of bruising. So I hit something, a door jamb or something. The question is, am I going to just bruise, or am I going to actually start bleeding? So that's the story. Thank you very much for that, Rick. And the other thing about that is that when I eventually Vanderweel decided that well, first of all, we Northwestern, as far as the Xofigo, there was no interest in Silver Cross to take me on as a patient doing any treatment when I was below 9. Somehow Vanderweel did magic at Northwestern. It should have been Silver Cross, which is a adjunct facility for University of Chicago. It's an adjunct facility for University of Chicago. But I finally they would not accept me that low. Finally, Vanderweel got got the permission. He got the somehow with his magic, he got the information so that I could go ahead and proceed with the um, Zofigo at Northwestern downtown Chicago, even though I was above 7.5. Now I was below 7.5. Excuse me. And so that's kind of where I sat. And then so we said, okay. And when I talked to Vanderweel and a Dr. Nirala, who is very, very good, he kind of, even though Vanderweel has been very involved, um, a friend of mine and oncologist I have a lot of respect for, um, we got together and they agreed that would give a shot at Zofigo, even though we really didn't expect anything to come from it. So about that time, and then soon thereafter, I started a Zofigo regime, and I lasted through 2 of the Zofigos, and I ended up at that point that I was like, curled up in the corner of my bed and like, okay, let me die. I'm done. And so we said, okay, that's not working. And so what we did is we went and talked to the docs, and we finally agreed uh, that we weren't going to do any more of that. So we stopped doing the Zofigo, and we had another couple of days of basically pretty tough sledding. And so anyway, so we didn't do any more of that, and that turned out to be within a couple of days the symptoms cleared up, but clearly Zofigo was not going to work very well for me. So that's kind of where we are, and we are right now. As part of that discussion, we all agreed that it probably made sense for me to go into hospice because I wasn't getting any better. When you have your wife and your daughter have to watch you kind of curl up in the corner, you don't really like that. Since then, I've been okay. What I really find most of all is my waist down, particularly my left leg. Initially, I have a lot of pain. I mean, enough pain that I quickly moved from active from being able to get around to a in a wheelchair to I couldn't even. Thanks, Rick. I could not. Just. It was just too tough. So, oh gosh, I got off that. Am I supposed to get off that, Lynn? Anyway, and so, oh guys, be patient. I'll get back to you. Um, anyway, so that's kind of where I am right now. I am feeling better from the waist down. It's just the big things for me initially were that number one, I have a lot of pain in my I can't support. I have tremors and spasms in my left leg. Like I'm sitting here in my living room tonight and watching TV, enjoying company with you great gentlemen, which I'm sorry I have to spend time with you because of our disease, but so be it. But I feel pretty good. For the waist up, feel pretty good. The big issues for me is that I number one have the big issues for me is that uh, I'll get it out, guys. I am in a situation where I'm sore in my left leg, and in fact, about a couple weeks ago, I decided I was going to go to doing I was going to do some sort of so I've kind of gone from being just I've been gone from being hospice to being like really being limited hospice to
So let me come in a second, Mark.
yeah.
I think the questions and David H. Stay put. We'll get to you next as soon as we're through with Mark. But are you? The first question is: are you thinking of restarting some type of treatment?
I'm thinking about it, Rick, but very, very vaguely.
Vaguely. And
I'm
if you started that treatment, who would be your quarterback doctor? Would it be Vanderweiler or would it be Stadler?
It actually wouldn't be Stadler. It'd be a guy down the street named Narula.
Oh, that's right.
Sunil Narula. He's my quarterback, and
Yeah,
so
yeah, yeah, yeah.
I would go to him and change it. But as of right now, I have no reason to believe. The idea right now is to get off everything, and then if it turns out that that I feel better, basically just ride it out to the end. If it turns out I don't feel better, then so be it. And uh, so, like for instance, 3 weekends ago, I had my whole family in. We had a spectacular time. Spectacular. Got together, talked about old stories with family, all this stuff. We did that for a couple weekends, and so that was spectacular. Anyway, and so we've done that, and actually, I'm feeling, except for the left leg, having these spasms and so on. I feel much better than I did 3 weeks ago when, you know, again, I could almost die. So right now, I'm off treatment. We went and looked at a couple of treatments that were potentials. So far, we haven't found anything. You know, Vanderweel and Dr. Narula, they're on they're on call if something, somebody miraculously calls up Rick and says, you need to do something else. If that comes, then we'll talk about it. But they'll probably put me in a padded room somewhere to do it because right now that's
Yeah.
not. So I'm
So
not planning. Go ahead.
let's open it up to the guys and see what they'd like to
Yeah.
talk to you about.
Yeah.
Mark, I'm wondering, are you on pain medications?
Yes. When I went into hospice, I went into pain medication. So I'm taking we moved it up a little bit, but I'm basically um, uh, I'm taking treatment as far as taking. I keep wanting to call it cocaine, but it's not. I keep taking. We're treating the pain, and at this time, the idea is that I've agreed that I'll go ahead and take the pain medication, and they'll keep me on that and keep me comfortable. But they won't, they're not going to do anything else active to take care of any discourse, any discomfort I have. I do have the option if they come up with some wonder drug. I could get out of hospice, go into whatever this new miracle drug is, and then come back eventually. One of the things that's not in that note, uh, Rick, is that I did go see Dr. E in Houston, and she was helpful. She really, in the process, has not really had anything of any great import or great opportunities that she's identified that I could use it. She might come up with something. I got to say, I talked to her remotely, and she's been okay, but she hasn't been very available. So I don't know what's going to happen. Their staff keeps rescheduling my appointments as
So,
they were. Yeah.
there's a question from. Go ahead, Joel. I'll ask you a question.
Yeah, Mark, do you have a palliative care doctor from hospice?
Yes, I went initially from. It's a great question, by the way. I went to palliative care, and then when the palliative care didn't really help that much, I went from palliative care. Within a week, I was still, feeling pretty crummy, and so I went from palliative care to hospice. I could always, if they come up with some new, you know, whatever kind of drug, I could go back to the palliative care. But right now, I feel pretty comfortable that I've, kind of done something with that you know, particular drug, particular protocol. But that is an option. But as of now, Dr. E and anybody else has not come up with a much of an option that's going to lead me down that road.
Mark,
Right.
I would just say make sure constipation can be a serious problem when you're taking these pain medications. Don't let that get out of control.
Yeah,
Hopefully they're giving you things to keep your bowels moving.
that's great input. Right now, I'm able to control any constipation issues just with taking Duplex in the morning. If I get more serious kind of stuff, then we'll have to think about other stuff. In that list, which I'm not sure if Rick again, I'll get it back out to the group. And that list is I did get SBR. I did get radiation at one point, and when I got that, I did at one point. It was maybe, I guess, a year before this whole thing. But I ended up at one point that I was taking palliative. I was not taking anything, and I found I found myself a little bit more disoriented and so on. I do have some disorientation. I mean, I do sometimes kind of lose my train of thought, as you can see and experience. It's wonderful, and also I can I'll become constipated, particularly when I had radiation of my pelvis and my I was under. They just basically, because I was getting a lot of this pain I got initially when I went through just going on my own. Uh, I had a lot of pain across my groin, lower hips, and my uh, you know I went through a lot of pain in my pelvis and hip, and so the way I treated that was aspirin and stuff. We went through palliative care for a little bit, but that didn't help. But I got that like in August, and it was more like, oh, I don't know. Len, it was probably October, November. I had the treatment at that point, and I got severely constipated. I mean, really bad. I mean, everything just backs up. But that's one of the worst periods of time I've had in this journey, is that I had terrible pain, and so, but I got through that. So, other
All right,
questions?
Mark, we do have a new fellow with us tonight, so we do want to leave time to get to him. Is that all right with you? If maybe you can
Yeah,
come back next week and
yeah.
let us know.
We'll take. I think that's great. We'll take up the story next week, and
Yeah.
I guess my ask of the group, if because you guys are all talking about exercise and stuff, of which I've had extensive discussions with Rick, is if there's something I'm missing, but my wife Ann, um, he's very, she's very optimistic that there might be something waiting out there for me. I think I've kind of checked
Okay.
boxes, but yeah.
All right. Very good. On
And
that note,
the other thing
we'll.
before you move on, Lynn, the
Yeah.
other thing, in this discussions I've heard before, we've often go through the discussion of, when do you just kind of throw in the towel and say that's enough? And I think that's kind of where I'm at now. If something happened, I mean, like right now tonight, actually, versus other nights, I feel great, and I actually, I had a nice dinner, and I felt good, and everything was pretty good. It was great. We had a nice dinner. I had a hamburger, which, I went through a period of time where I was like, I call it table to mouth, that between my table and my mouth, I lost my appetite for whatever we're eating. I've kind of gotten through that. But other stuff just doesn't seem to be working.
So, Mark, is it okay if I put your email address in the chat window?
Yeah, absolutely. And if anybody, well, obviously, if you say, well, Mark, have you checked this box? You got one left. I'd be glad to do it. I'm 72.
So, I'm going to put it in the chat window.
Yep.
I think this issue of when do you throw in the towel is a tremendously important one.
Oh yeah, particularly for me.
Is there, and we, like I say, we've got one other new guy, but maybe if you can come back next week on Tuesday, it's a little earlier in the day. I'd love for us to start with, when we come to you, let's all contribute on that issue.
That would
Because
be
if we
great.
start it now, it'll take us right the way through to the end.
Yeah, I agree. And if there was something out there that, I mean, really right now I'm at a point where about the only solution I can see is if I get a miracle where it just goes. Or my body, which has got me 9 years into this thing, my body gets to a point where it says, I'll find a way around this. But as of right now, I'm not seeing that.
Okay, well, look, let's we've got to move along. We'd love to talk about when to throw in the towel, but let's do that if we can next Tuesday. Dr. John, you're going to be in the hot seat, and and John's a very good person to run that conversation. But Len, you want to move on to David? David, I think.
Yeah, sure. Mark, thank you very much, and hopefully we'll see you next week, and we'll pick up where we left off here. Now I
Well,
want to move to David H., who is new. David, are you going to be talking to us on the phone?
Yes, I hope. Can you hear me now on the phone at least?
Yeah, this is good. Very good.
All right,
All
I'm
right.
going to set the phone down, and hopefully I can run this. All right.
Yeah. Okay. So here we go. I'm going to start asking you a few questions. First of all, how old are you?
Yeah, and I've got the list. Jim sent me the list, so should I just run through
Okay.
what I've
Sure. Go ahead. Go ahead.
a little bit. So, and apologies for the audio issues, and thanks for letting me get on the forum for the first time. So I'm 65 years old. I live in Oakton, Virginia. I feel like I've always had very good health, active lifestyle, good weight. So this all hit pretty hard. How did I hear about AnCan? Jim Marshall, thank you, Jim. I was on the Innova Shar Living with Cancer, Prostate Cancer Support Group last week, and Jim thought that this would be maybe a more appropriate group for me because of my situation. So thank you, Jim. When was I first diagnosed? Was April, May of this year. Metastatic prostate cancer with a hot spot in my right pelvic bone. I had PSA back in 2021. They came up to about 6.3, went to 6.7, 6.5. My primary doctor, maybe he was I wish he had acted a little sooner. And then finally it bumped up to 9.5 in December of 2023. So that's when he said, all right, you need to see a urologist and get going on this. Who was my doctor when I was diagnosed? My urologist has been Dr. Nathan Roberts, Innova Loudon Hospital. And his assistant did a biopsy back in April of 2024. So I can just give those results. That's question number 6. On the biopsy, how many needles? 13 needle samples were taken. 8 were benign, and 5 were prostate adenocarcinoma. And of those 5, 2 had a Gleason of 4.3, and the other 3 had 4.4. And one of the 4.4s, there was a mention of cribriform, which is in your question here. I'm not exactly sure what the significance of that is. I got a feeling it's probably not good, but it was meant. I looked at the report last night and I saw that. As far as treatments, when I was first diagnosed, I've been on hormone medication. My urologist put me on Orgovix for the first 30 days, and then I switched over to my primary oncologist, and he's got me now on Xtandi, 160 milligrams per day, and I've started Eligard injections. I had my first one about 2 weeks ago. Radiation is yet to come. I think that will probably start in September because of the bone spot. I'm going to be meeting with my radiation oncologist later this month. Question 8 on what has been done so far as testing. Bone scans, I don't think so. I have had a bone density test, and that was normal. I did have an MRI, and the PET scan, yes. And that's where they determined that there was a right pelvic bone metastasis. And that was a reading of SUV 58.7, which I'm not sure, the significance of that. The doctor said, okay, that looks like
Pretty
a
intense.
Hobbs. Yeah, okay, that's not good. Where are you being treated? Okay, so right now I'm pretty much hooked into a novo Cancer Institute. I've heard very good things about that organization. My primary oncologist is Jonathan Allen, and my initial radiation oncologist was Michael Eblin, and I'll be switching to Dr. Chapman, don't have his first name, because he works out of Fair Oaks, which is closer to where I live. And, when I start the radiation, I think that's going to be a lot more convenient to go to that hospital. So I'll be meeting with him in a couple of weeks. What are your treatments being administered? So as I said, they've got me on a hormone regimen and then radiation to follow. As far as genomic testing, yes, I did do that. Ambry genetics testing, which came back negative, no clinically significant variants detected. So I took that as a good sign. So that's sort of I think that answers all the questions. Do you want me to pose a couple of questions before I open it up to any questions anyone else has?
Yes, please. What questions do you have for us?
Okay, well, just a couple. So my radiation doctor, he's asked that, or he's recommended that I do a rectal spacer gel fiducial markers, which, I'll do that. I don't have a problem with that, unless I'd like to hear if there's any thoughts on how smart that is. If someone maybe privately could give me a recommendation for a urologist in my area, physical area that has performed that, I would appreciate it. The urologist I had been using is out in Loudoun, which is quite a distance away. And I got the sense once he found out I had metastatic, he, was less interested. He's more into the removal of the prostate. So if anyone has a recommendation on a good urologist in the Fairfax, Virginia area, I would appreciate it.
Hold on a minute. Do you mean a urologist or a radiation oncologist? Because they're very different.
Well, what my radiation oncologist said is I would need to go to a urologist for the rectal spacer gel. Is that not the case?
No. Usually the practice, the radiation oncology practice, will arrange for that to be put in wherever they are. They don't usually, I've not heard of them referred out, although most of the time we work with centers of excellence, but they should be able to suggest someone to you. What is the radiation treatment they're giving you?
Well, I don't know right now. Again, I'm switching over to a different doctor because of the hospital, and I'm meeting with him later this month. So I think I'll get a lot more details, but I'm expecting that to start probably around September.
So what you don't want to be doing is 40 odd. I don't know if they're planning on radiating the gland, which it sounds like they are if they're talking about a spacer, but you don't want to be considering 45 treatments. The optimal treatments for somebody like yourself would probably be a couple of treatments to the gland with SBRT, and then maybe 25 treatments across the pelvic girdle. So that's going to save you an awful lot of trips.
Yeah, they weren't that specific on how many. It was minimum of 4 weeks, and it could be 8. I think was what
Okay,
initially.
well, it shouldn't be 8. If it's 8, they don't have the right equipment.
Well, I'm hoping it's in 4 weeks. Thank you. And is there agreement that the rectal spacer gel is a smart way to go? They said it would help avoid burning of the colon and other issues. Is that pretty much?
Yeah, I think there's general agreement that that's smart.
Okay. All right, then we'll do that.
What
I
about the
had it
role
done.
of,
I'm sure many people here have had it done.
is there a potential role for brachytherapy here, guys?
Well, there is, but you're better off getting two or three doses of SBRT rather than the brachytherapy, John.
Okay.
I mean, traditionally it was brachy, the high dose, low dose or high dose plus the IMRT, and if they're going to radiate the gland, which it sounds like they're willing to do for David, but Mac Roach now has moved to SBRT, and a lot of other doctors have moved to SBRT. That's the protocol that Daniel's dealing with right now. And I think, Daniel, you're doing that with a non-Kaiser radiation oncologist, isn't that right?
That's correct. That's Dr. Nasser over at the Virginia Hospital Center in Arlington, David. And when I discussed the spacer with him, the downside of that is he recommends wait until he actually starts. His procedure is not do the SBRT first. He does the IMRT first, 20 to 25 sessions as Rick just indicated. And once he gets into that, then he'll look at where the specific cells are, because if they put in he's indicated if they put in the spacer too soon, sometimes the cancerous cells can get behind the spacer and it causes problems later on.
I'll ask that question when I meet with Dr. Chapman later this month on the
But
timing.
I'm very happy dealing with Dr. Nasser. If you want a recommendation, I can give one.
Yeah, that would be great. And you said it was the Virginia Hospital Center? Or?
Correct. Virginia Hospital Center in Arlington.
See, we've got Mark, Dr. Mark. Do you have a comment?
Yeah. So when I had a discussion about doing lymph nodes in the pelvis, they were talking about including it as part of the SBRT. The use of a spacing gel kind of depends on the margins that they add around the tumor area that they're going to treat. If it's an MRI guided treatment, they have less fluff around the target area. So with those, about 50% are going to get a spacer and 50% don't. With a CT guided treatment, they add a larger margin because most of the CT machines, other than CyberKnife, do not track movement during the course of the beam being on. So if you've got a gas bubble that pushes the rectum in, you're still going to be radiating the rectum. And by separating that with the spacer, that can be helpful. Now, there are two gels, Spacer and Barrigel. And the Barrigel is a little bit trickier and more difficult to use. And a significant percentage of the people who get the spacer don't have uniform spacing or elevation of the prostate away from the rectum. Barrigel seems to be easier to manipulate. Not all the guys have experience with it because it is newer, but it appears to be safer and less issues with injection into the bowel wall and trouble with it. The other thing is a balloon that they have released called BioProtect. So if I were going to choose to do it at this stage, having looked at all that, I would probably do Barrigel or BioProtect and look away. But I think more important here, you're looking at switching for convenience. And I think the most important thing is to make sure that you're not going to a convenience center where in the morning the guy is working on breast, then doing brain, and then doing prostate. You want to be in a program where not only the radiation oncologist, but the team of people who are operating the machine are familiar dealing with genitourinary or prostate bladder kind of cancers. If they're doing a little bit of this and a little bit of that, I think that's really an indication to travel for care. I was living in Atlanta, and that's the kind of treatment that I was offered there. And I basically said no way and traveled across the country to UCLA because I knew that I had a top-notch team across the board. So it's not just the docs that you are dependent upon. You're dependent upon the radiation physicists, the radiation therapists, and really the entire system to get a good outcome.
All right, thank you. What is the significance of SUV 58.7?
That's how bright the lesion is compared to liver or other tissue in the body. So that's a very high number. Usually, I think if it's above 15, they become more suspicious of it being a metastasis. So at 58, pretty good sign that that's really a metastatic lesion and not a false positive.
Thank you.
Yeah, I would talk to the radiation oncologist, ask him if he plans on radiating that spot in your hip, because that is very hot. I would guess that that's no question that that is a cancer lesion. That's about the highest I've ever heard, frankly. Let's see, Joel.
I think you have to get some clarification on exactly what the treatment is.
Yeah, for sure.
Nova.
Joel Blanchette.
Yeah.
Go ahead, David.
No, I'm asking Nova Shar. I mean, I pretty much thought that that's the leading cancer institute in Northern Virginia.
No, that should be Johns Hopkins.
Up in Baltimore, yeah.
Yeah.
Okay.
That's the Center of Excellence. I'm only 6-7 miles from you. I'm in Reston, as you can see, and there's no beach there. But I did get 6 treatments of SBRT from Dr. Eblin at Loudon. I also go to Fair Oaks for Dr. Josh Allen. So I have the same 2 doctors that you said originally. And I'm going to put my email address in the chat. So if you want to talk to me, Jim Marshall, Jim and I know each other very well. So I'd be glad to help if I can. So Eblin is very good. Allen is very good. He also uses Johns Hopkins as a resource if he doesn't know something. Allen's staff is the best of all the doctors I have, which are at least a dozen. He has the best staff of them all. So anything you want done, it can get done, and it is done in a very quick fashion. So I recommend him too. So anyway, I'll put my email address in the chat. Again, I'm close. I'm only at 20 minutes from Fair Oaks and 25 minutes from Loudon, and all my radiation was at Loudon Hospital. So yeah, it's not so bad.
Yeah, send the contact information, and that is my primary doctor is Josh Allen. I said Jonathan. Right.
Yeah, Joshua Allen. Right? Mm-hmm. Correct.
All right, Dr. Jeff, go ahead.
Yeah, David, you also made mention in your question about fiducial markers. And that is That's not optional. So, and urologists normally insert them. It's a very quick procedure. They put small metal pieces, little metal balls into your prostate so that they can hone in with the radiation because they show up on x-ray. So that's like a 15-minute procedure, but prior to getting radiation, you need to have the fiducial markers inserted.
Okay. That's, we will do
Any
that.
other questions for David?
Yeah, I just wanted to follow up. It might be that they're not giving you detailed information on RT, radiation therapy, yet because of the high SUV that you have. They're probably mulling that over. But once that's evaluated and you determine where you want to go, it should be pretty straightforward.
Yeah, what they told me is they wanted to get the lesion size down as much as possible before they start the radiation. And also we had some travel issues and they wanted to make sure, I would be able, once I got started, I wouldn't stop the treatment. So.
Mm-hmm.
Joel, your hand is back up.
Yeah, David, did I misunderstand, or did you say that you were on Orgovyx and Eligard at the same time?
No, I started just 30 days of Orgovyx, and then when I switched over to Josh Allen, he switched me to the Xtandi and also the Eligard. That's what I'm doing now. The Xtandi and Eligard.
All right, thanks.
I'm not sure why they would switch you from Eligard to Orgovyx. Right now, there's some evidence suggesting it's not entirely clear, but that there may be fewer cardiovascular side effects with an antagonist versus the agonist.
Yeah,
And,
Dr. Mark.
Yeah.
Dr. Mark, they started him on the Orgovyx as an antagonist and then switched him over to the Eligard, probably for financial reasons, is my guess.
Okay.
Okay, so instead of giving him a buffer, they just it's like they gave him a Firmagon shot one-off. Frankly, Dr. Mark is exactly right. They should leave you on the Orgovyx. It's a better drug, but I don't know why they switched you across, but practically it probably isn't going to make a lot of difference. I'm sorry, guys. We're in a storm here, and I just got bumped off.
I'm glad you're back, Rick.
Yeah, I just wanted to say to David, the one thing that I do think is worth a discussion with Dr. Allen is why he started you on Xtandi rather than abiraterone. Do you have other health issues or not?
No. Actually, as I said, I think I'm quite healthy. So he just switched me off the Orgovyx after I gone through my 30-day supply, and now we be on Xtandi and Eligard.
So the Orgovyx and the Eligard are very similar drugs. They work a little differently, and as you now know, one's a pill, one's a shot. I mean, we don't need to get into the weeds of the differences. But the enzalutamide is quite different, and it's worth a discussion with Dr. Allen why he chose to give you enzalutamide first, which is Xtandi, rather than abiraterone or Zytiga. The reason for that discussion is we seem to think that it's better to follow abiraterone with something like enzalutamide than to precede it. So the first drug, the research tends to indicate that the first drug it should be abiraterone, and he may have reasons why he switched it the other way around, and I'm sure the guys can discuss that. But Dr. Jeff, you want to say something on that? I know you looked at that. You looked at that extensively yourself.
Yeah, I think abiraterone first is the better approach.
All right, David, we've got three more guys. I'd like to move on. Are you okay for the moment?
Yeah, thank you very much. Again, apologies for the initial problems getting on. So
No
I'll just listen.
worries. No
Not
worries.
your
Thank
fault.
you.
Does Jim have your email, or if not, we'd like to put you on the mailing list so that you get a reminder for next week and in future. So,
No problem. He is on.
Oh, he's on. Okay.
He is on. I took care of him.
All right.
I'll work on audio. Thank you.
So the lineup is Richard Fisk, then Cliff Collins, and then Al Latimer. So Richard Fisk, you're up.
Okay, this is just a quick one. I've had trouble with hot flashes and been trying various things, including Ember Wave and various diet issues, and finally got it through my thick head that people had been talking about exercise. And beginning a week and a half ago, started exercising significantly, probably half an hour a day on the elliptical, getting my blood or my pulse up as high as I could, close to 100 at this point with the drugs, and then every other day doing weights. And my hot flashes have diminished to the point where I have one, maybe two a day, and neither of those are very bad. So, absolutely, exercise enthusiastically kills hot flashes. My personal experience.
Okay, thank you, Richard, for that. And
Jimmy,
who is our?
Jimmy, what do you want to say about that, Jimmy G?
How did you know I wanted to say anything? The only thing I want to say is that hot flashes were not an issue for me either. And I got had a few warm moments, but certainly nothing major. And I am pretty sure that my exercise habits and, somewhat sensible. I'm not beach ready at any point. I'm too old for that. But I mean, really keeping the weight to a sensible composition. I don't have too much fat on me, and I exercised a lot. And it was spring and summer of 2020, pretty hot, and locked down COVID, and I didn't have a problem with hot flashes, so I can endorse. I always thought it had something to do with it. You won't find any literature on it. You won't find any data on it, so don't look for data or proof. Just me and Richard. That's all we got.
Can I just intervene with something for David H? David, the NCCN guidelines indicate that you should be somatically sequenced. And Dr. Allen should be aware of that. That's not just the germline test that you got to see if you have anything inherited. Your cancer should be sequenced. And you might remind Dr. Allen that you would like your cancer sequenced. There are a number of reasons. It might indicate a better treatment. And another reason is because there may be changes as you move forward. So you want to see where you are today as a baseline and then test yourself again later down the road. But the somatic sequencing is getting more and more important. It's covered and it's recommended in the guidelines for somebody with metastatic cancer. Sorry, Len.
Okay, no problem. And I want to circle back for a moment to Nick Young. I hope you were listening there. Exercise can diminish hot flashes, Nick. You weren't too sure about that. Okay, so Cliff Collins, you're next.
Hi, I've been on a drug holiday for about the last 9 months, and I recently was scheduled to do a CT scan, and last Monday I did a bone scan today, and I have a PSMA PET on next Tuesday. The bone scan didn't go too well. I've been having a lot of pain in my leg and nerve pain, and so they did the bone scan, and the doctor saw some anomalies in the bone scan, so I had to do it over again today, just on the pelvic region, and I didn't get any clue. I don't visit my radiation oncologist until August the 2nd once I get all these done. I've never had a PSMA PET scan. I was non-detectable 2 weeks ago. What can I expect from that? What should it show if I'm non-detectable? If my PSA is
Cliff,
non-detectable?
Shouldn't show
Cliff,
anything.
this is John. I'm a little uncertain about why they're doing all these scans now if you're still undetectable.
I don't know either.
Okay.
You have no
Usually the time
symptoms?
to, take a second look at everything is when you recur.
Yeah. So, but I was wondering why. I don't know what showed up on my bone scan today, but the doctor was very inquisitive about it, and I had to lay there for another 27 minutes while the machine went around again. So, I did see the first scan, and my pelvic area was lit up like a Christmas tree. So,
That could possibly be the radioactive material collecting in your bladder in the pelvic area. So if you saw a big light up down in your pelvis, it might not be anything to worry about.
okay, I hope that's the case. Because I haven't had any. I was initially diagnosed only with lymph node um, involvement, nothing else. And like I said, I've been off of the abiraterone and the Lupron since November. And my testosterone is back up to 455. So, yeah.
So, Cliff, I would ask your doctor, why are you ordering 3 scans on me when my PSA is undetectable? And
Yeah,
I presume you're asymptomatic. You have no
yeah,
issues, no pain,
no,
nothing.
no issues whatsoever. So I'm kind of baffled by that myself. So I'm going to ask.
Okay, is this Walter Reed? Because I know you did go to see Dr. Palla. Where are they doing this treatment?
This is at Walter Reed, but I'm still seeing Dr. Pallet.
Okay. I think what I would do is run this past Dr. Palla and say, I don't know what's going on here.
Yeah.
Because
Yeah, okay.
sometimes it's been our experience, I hate to say it, but I think Jim Marshall would agree that Walter Reed can't get out its own way when it comes to dealing with metastatic prostate cancer. And our advice to you would be, I'm assuming that you have TRICARE, is that right?
Yes, I have TRICARE and I have.
Get your ass out of Walter Reed. I mean,
Okay.
don't even mess with Walter Reed. If you're seeing Dr. Palla, go over to Sibley. Let Sibley Johns Hopkins deal with you.
Okay. I'm
You
gonna
know,
do that.
and we've said that before. There are good reasons for it. Walter Reed doesn't have any GU medical oncologists on its staff,
Right.
and they don't know what they're doing when it comes to more advanced prostate cancer. General Joel will tell you that. We've got other guys who will tell you that. You've got to get out of Walter Reed, and this is a very good example as to why.
Yeah,
And
you're right. You're right.
I would make an appointment. Dr. Palla is very nice, very good. You've seen her.
Yeah.
And, pursue Dr. Palla, Cliff.
I will. I will take your advice. Thank you.
And report back to us. I don't know. I mean, I don't want to slam the military here. I got too many high-ranking officers that are in this room right now. So please feel free to put on your mics and say whatever you'd like to say, General Joel or Captain Jim. Do you have any comments on Walter Reed?
Walter Reed can remove a prostate like you would not believe. They are good at
All right.
Joel, anything you want to add?
Yeah, you're 100% correct, Rick. That's all I can say.
Thank you, gentlemen.
All right, thank you, Cliff.
All right.
Al Latimer, your cleanup man.
Hi there. I haven't been on this for a while. Been sidetracked with this and that. I have one thing specific I'd like to bring up tonight. My Our youngest son just turned 39, and I forced him to have a PSA test and convinced the doctor to do it because of the family history. His PSA at age 39 came back at 2.7, and the first time I had a PSA test when I was 42 or 43, my PSA was 2.7. So we have an appointment with a urologist that's in network for him tomorrow to kind of start the ball rolling on him being followed. And well, I guess two things. One, I imagine many of you have sons. They need to be watching this. And I guess if you have any comments about specific things we should be asking, saying when we go see him tomorrow. The urologist, I don't know, just somebody that was in our son's health insurance network.
Al, did
So
you have any germline mutations yourself?
did I?
Yep.
Well, I've had multiple tests, and one time BRCA2 came up, but I've had multiple tests where it did not also.
Have you done a germline test, Al? Just to
Yes,
look at inherited.
yes.
And what was the result of that
I had
test?
I had one just recently with Dr. E at Houston Methodist, and it didn't come up with anything.
Okay, so I think that's what we need to know right now, because the BRCAs are somatic. They can come in, they can go out, as you well know. But the germline is definitive. And if Dr. E ran a germline and it was negative, who was that with? Ambry or somebody like that?
No, it was Tempest.
No, Tempus is a somatic test, Al.
Okay, well, they did one. I'll have to go back and look and see where it was with.
Okay, what you need,
And
what we
I've had them before too, and the inherited one has not shown anything. I had one at MD Anderson 3 years ago. It didn't show anything. So
Okay, you only really need to do the inherited one time, as long as you do it, with a decent company. Like even if it's color or Ambry or Illumina or whoever it is, but you only need to do that. That can just be a cheek swab. Right? Sometimes it's blood, but it can just be a cheek swab. But that's a very different test to these repeated ones that you're doing that like Dr. E did.
I'm pretty sure she did an inherited one too. I'll have to go back and look. I
Okay, so
don't remember.
that's a really good point on Len, a great pickup on Len's part. We oftentimes recommend that you start getting, if you have kids and you have advanced disease, start checking, get a baseline at 35 is what we say. But a lot of times you can't get your kids to do that.
Well, yeah.
I would say that yes, you should be concerned. I would say that ideally have your son followed at a center of excellence. Is there a center of excellence in his providers?
No. So
Okay.
I'm just starting with something easy, simple, local, and we'll see. It seems to me that you talked about starting at 35. Well, I haven't been able to get him to do it until now. So we don't really have a baseline yet on him
Right.
as to what his normal is. I know 2.7 is when the test comes back, it says normal. Under 4 is normal, but for a 39-year-old, I would assume that 39 is not really normal.
Well, my PSA was frequently higher than 4 in my 40s and in my late 30s. I got my first test when I think I was 39, 38 or 39. They were just starting it at the time. And so my PSA came back repeatedly relatively high. Now, I probably had the prostate cancer then. I wasn't diagnosed till I was 56. But I think that it's a very smart idea on your part to get it. I think my feeling was, if that was me, I'd want to get tested at least once a year. And if there's changes in that, to then talk about what to do next. I also think it's a very valid conversation to have with Dr. Belusic and get his
Yeah,
guide.
I see him next week. I'm going to talk to him. I'm going to talk to him next week. I had talked with Scholes the other day. I told him about it. He said 2.7 is definitely not normal for someone that's 39. Um, and he thought that Tom, my son's name is Tom, that he should have an MRI right away and see if they can see anything's going on in there. Um, it seems to me at least we should have a baseline first, maybe do another PSA in 6 months or something, or even 3 months, and
Yeah.
see see where he's
Yeah.
going.
Yeah. It's especially with your history, it's very, very likely. And I agree, whether you should dive right into an MRI, I don't know, but you've got to keep a very close eye on it,
Yeah.
because if there is something there and it's in the prostate and you can pick it up, then the chances are, if God forbid he does have any cancer, it's going to be aggressive like yours, and you can nail it early.
Yeah. As
Al,
a
this is
point,
John.
yes.
Al, is he by any chance 6'4" and 260 pounds?
Nobody's. He's 6'1" and 240.
Uh-huh. He might just have a very large prostate.
Yep.
Well,
I mean,
that's
not that he shouldn't be followed very
so.
closely and
The
consult an
other
expert.
Another interesting fact about that is that his testosterone level is very low, um, unusually low for a 39-year-old, and so that's another piece of the puzzle. And also, to put it in perspective, our other son, who's 4 years older, his PSA is zero point 0.4, and I would think that's a little bit more normal. And he's been following his for quite a while, and it's been very steady. Um, But this younger one, he does not want to go to a doctor. I'm going to drag him tomorrow. He's going with me. We're going to get this ball rolling.
Good job. Can we switch this up? Can we switch
Yeah, I
the?
just recently read that. I was just going to say, Rick, I just recently read, although I can't give you the citation, that when you're in your 40s, your PSA should definitely not be more than 1.2. And Dr. John posted in the chat that he had heard, and I heard this too, that if your PSA is less than 0.5 at 50, you'll never get prostate cancer. I don't know how they can be so sure about that, but I remember hearing that also. Go ahead, Rick.
Yeah, I want to come back to which trial you decided to do, Mr. Latimer. We don't know. Are you in ARV trial? Are you in the SPOP trial, or
Yes.
are you in
Okay.
nothing?
I'm doing the SPOP. I'm doing SPOP. I'm 2 weeks into it. The other one, well, logistically, it just didn't work out. Um, But I'm doing the SPOP trial in Miami. I've had 2 weeks of pills so far. They've done two biopsies on lymph nodes as part of the trial. The first biopsy, I ended up with a hematoma and ended up in the hospital for a couple of days. Lovely. But it resolved itself. And so this trial is 2 weeks on the pill, taking the pill every day, or pills, as then 1 week off. I'm on the week off right now. Um, I have blood work done every week. I have not seen any effect on the PSA yet. There's going to be another PSMA PET toward the middle of August, and I guess that's when we'll really know whether this is helping me or not.
So can you please, since we have a few SPOP people in the group, including Dr. John, I know is one, and there's a couple of others, would you be kind enough to put the trial number in the chat? And
Sure.
also, we're wondering what is the protocol? What are they doing? What are you getting? What's the drug?
The drug is M1774, whatever that is.
Okay.
I don't have that. I don't have all the. Yeah, so I can trying to think where I have the link to the trial.
But send it to us, because there are interested parties in this group who would like to know about that trial. Am I correct? Okay. Anyone other than Dr. John knows that they have SPOP mutation and SPOP mutation? I know we've got at least one or two other guys that have SPOP, but I just wondered if there was anyone else in the room.
Dr. Jack, but he's not here anymore.
Oh, was it Dr. Jack? Yeah. Oh, he'll be sad to miss this part. So, and how are you feeling on the drug?
I have a little bit of fatigue, but nothing like when I was on Taxotere. I have some constipation from it, some dry mouth, but not the dry mouth. Nothing like when I was doing the Pluvicto, and trying to think where I had the constipation. But the side effects have been pretty minor, relatively speaking.
What was your PSA level when you entered the trial?
150.
Okay.
And it's about 170, well, about 175 or something right now. The PSMA PET I had before I started, it was in several lymph nodes, and for the first time, it was in my spine too.
Okay, so that was my next question, which I assumed that they had done baseline.
Yeah, they did a baseline a few days before I started. That was one thing I didn't. That was one thing I didn't like about the other trial, is they weren't doing a PSMA PET. They were just doing the old standard bone scan and CAT scan, and I wasn't really sure what good that was going to do. Anyway, the other one just didn't work out logistically.
That's okay. No, I mean, that's fine. And is Dr. Belusic the principal investigator on this trial?
No, he's not the principal investigator, but he's the one I'm working with on it.
Okay. No, that's great. I mean, it's not great that your PSA is going up. It's good that you're in the trial. It's good Dr. Belusic is involved, and that's so. But thank you for the update. Keep us posted and send us that NCT number. I might be able to find it.
I'm looking for it now.
Okay. Well, don't worry. You can send it to me, and I'll send it on to Dr.
Okay.
John.
Well,
And
that'll be easier. I'll just I've got it here. I can just forward you the whole thing.
that's okay. Thank you.
Okay, I'll do it that way. So, and we'll keep you posted on on my loving son. I sure hope he doesn't have to deal with this like I did.
Yeah,
At the
we
very
all.
at the very least, he's going to catch it sooner than I did.
Well, that's for sure. And I think this is a great topic for everybody. If you've got kids and they are over 35 and you're in this group and they haven't been tested, please, please get them to get a test. I won't ask who has done it and who hasn't because I don't want to embarrass anybody in the group. But I will say it is so important if you have a history to have those kids, get them to get a PSA test, please.
I doubt anyone here has as bad a history as I do because my father had prostate cancer, his father had prostate cancer, his brother had prostate cancer, my brother has prostate cancer. And I'm sure hoping that it doesn't go, I'm not passing it on to another generation, but now I have 2 sons and 2 grandsons.
Oh boy.
Well, I'm amazed that your younger son, knowing that, is so resistant to going to the doctor to investigate why his PSA is as high as it is at his age.
Yeah, he
Is it
doesn't,
fear?
pardon?
Is it fear? He just, like
Yeah,
he's sticking his head in the
it's,
sand? I don't want to
yes,
know.
yes, I think so, mostly. But hopefully he will get religion here before long.
Len, we have a former moderator with 2 sons older than that, and they've refused to get PSA testing. And the former
Oh,
moderator had significant disease. So
yeah.
you can lead a horse to water, but you can't make it drink. And they see Tom and his other son. They see their dad. Some of them do something, some of them don't. But I just want to say it's so important. They don't have to get a DRE. Just let them get a baseline, and we can follow it.
Yeah, I had to convince his primary care doctor to order it too. She didn't particularly want to do it, but she did. 39 is way too young to get a PSA test, according to her.
Well,
Anyway,
you should educate her. Send her to look at the NCCN and the AUA guidelines because they recommend it if you come from if you have metastatic in your history. I think they're now down to 35 if you have metastatic in your history. Tell her to read the guidelines.
really? Okay.
Okay, I could go check it, but I'm pretty sure it's certainly 40, and I'm pretty sure it might even be 35 now in either the NCCN or the AUA. I can't remember which. I think maybe the NCCN.
So anyway, we're getting the ball. Let me get the ball rolling
Good
here.
job. Great job.
All right, guys, I think we can wrap it up, or at least I need to. My wife is
Yeah,
kicking
thank you,
me.
Len, for staying on. Thanks for staying on.
Okay, guys, we'll see you next week. Thank you all for a good
Right.
session.
Good
Ciao,
night.
ciao.
Good night.
Good night, everybody.
Thank you.